All right, so moving on to neurocritical care cases in PEARLS, we have Dr. Tsetsou taking the helm again. She has presented tests before. She's an assistant professor of neurosurgery in our department and a director of the critical care and intraoperative monitoring program for the health system. She trained in Greece and in France and joined us for a neurocritical care fellowship before then completing an IOM fellowship at the Massachusetts General Hospital. She has expertise in the treatment of neurological emergencies, including status, ICH, subarachnoid hemorrhage, and neurotrauma. And she'll be speaking to us today about malignant cerebral edema after cranioplasty. Welcome, Dr. Tsetsou.
Thank you very much for the introduction. Thank you very much. Just let me share my screen. 1 second. Can you hear? Can you see?
Yes.
Okay, perfect. So thank you very much again for the introduction. So today we're going to talk about a case and a malignant cerebral swelling after an uneventful cranioplasty that we had in the ICU at Mount Sinai West a couple of months ago. I have no disclosures relative to this talk. And so our patient, the patient we're going to discuss, she's a 44-year-old female with no past medical history other than some miscarriages. Completely independent, functional human being that initially she presented to us end of January after having a stroke, right MCA and A2, M1 and A2 occlusion back then with an IH initially 16. She benefited from TPA and then thrombectomy, though for the thrombectomy it was reported that required multiple passes because of the clot being reformed every time. Couple of hours after she developed malignant edema, required decompressive hemicraniectomy, and worsening the next day, she required even temporal lobectomy. Over the course of the day, she required to place an ICP monitor, a jugular valve catheter, as you can see here. That's her initial imaging, right, with a big stroke, malignant edema. Despite the decompressive hemicrania, she was keep swelling. We have placed a bolt on the other side. And here you can see the jugular valve to have a better idea of what's going on with oxygenation and ICP monitor. And after several weeks, 2 months, she got better to the point that she got discharged to rehab 2 months, like a month and a half later. And then while being in rehab, her trach and peg were even removed. To be aware, she was started on the anticoagulation for presumed hypercoagulable state, even though that was never really proved. There was no biomarker indicating that, but because of the miscarriages, the big stroke, and the idea that during a thrombectomy the clot was being reformed, she was started on anticoagulation. So the plan was 5 months after her decompressive hemicrania to come for cranioplasty. So that was her scan before the cranioplasty. As you can see here with the sinking flap, and then that's her immediate post-op video. So it was an uneventful cranioplasty. The Eliquis, like her anticoagulation, was held, I think 3 days ago before the surgery. And then immediately after the surgery, she got extubated. During the case, she got also Keppra extubated. There was no report, nothing reported from anesthesia, and that was her immediate scan post-op with some postoperative, like expected postoperative changes, some bleeding here, but overall nothing, no new stroke or nothing significant else. So she comes to the ICU after that. Her exam at the point of arriving in the ICU, she's awake. She can shake yes, no, says her name, which is like a significant improvement from last time we have seen here, right? And then she follows commands on the right. She's anti-gravity on the right side. Her left is still the weak side with left upper 1 out of 5 and left lower 2 out of 5. Her blood pressure was perfectly controlled. She had hemovac drain. And then we're all like very happy to see her like that, especially after knowing her during her previous hospitalization. However, at 6:30, the nurse called us because there was like a significant exam change. So at this point, she's somnolent but arousable, but she's not falling commands anymore. And her good side, she's not under gravity, she's only withdrawing. Blood pressure is still fine. Her glucose, okay. Everything else was like normal range. Her drain has drained approximately 150 cc at this point. So what would be your, what would you think, someone after an uneventful cranioplasty who has this extreme change, 3 hours after the surgery, and none of the rest them want to take, what would be the hypothesis? Ray, do you want to take a guess? What do you?
Yeah, I mean, for a post-op patient, my top concern is always like a post-op hematoma.
Would you concern of anything else in her particular case?
Yeah,
or anyone else you want to take? Yeah.
Yeah, I mean, and then the other common issues that we encounter are definitely on the list, including a stroke, and also like seizures.
Yeah, exactly. First, we thought maybe it's a new ischemic stroke, right? It's Ophelipris, and for a couple of days, of course, post-bleeding, she had already a small post-bleeding and the distal CAT scan, and of course seizures, because right now she doesn't move also the opposite side and she's more somnolent. So we get a CAT scan right away, right? That's what we see here. And does anyone want to comment on what are the new findings? Alejandro, maybe? Or who is there? Whoever wants from the reason to comment on the imaging, I can play also the video. Jeff?
I can do it.
I like the way you're
Yeah,
calling them
whoever-
people. You don't have to have them volunteer. You can volunteer them.
Okay. Okay, Jeff. Or Halima.
So the CAT scan shows cranioplasty in place. There is post-operative changes, some hyperintensity under the cranioplasty, and then a significant change in the amount of edema on the side of the cranioplasty as compared to the pre-op scan.
Correct, right? So this is the new hypodensity here, right? That's completely new. That here all was the previous stroke, but this hypodensity is posterior is completely new from the previous scan. So at this point, we say, okay, what's going on, right? It has a new stroke, it's edema, and then what the next step would be, we wanted really to complete imaging with see the vessels, right? However, the patient became unarousable, so she was brought immediately to the ICU back up, intubate, giving mannitol and hypertonic. We've unloaded here with Keppra, maybe she's seizing, right? And then at this point, that was a hypothesis, is any new LVO, venous sinus thrombosis. She's on the status, is hypoxic, though she was never really hypoxic during the episode of being the whole stay in the ICU. To say here, after being stabilized, we went for vessel imaging that was completely normal. So CTA was normal, CTV was normal, and then a new imaging after being intubated and stabilized your airway is that. Trevor, do you want to comment on the new imaging?
Yes. So, I mean, looking at the imaging, it looks like there's some enlarging extraaxial fluid collection there with obviously a very large holohemispheric infarct and encephalomalacia, developing encephalomalacia.
Correct. And then you see, right, so it's overall, I mean, you can see here, all this area looks infarcted, and then you can say even diffuse edema now on the contralateral side, right? We cannot really see the sulci, and that's she had the first CAT scan when she finished the ward at 3 p.m. and now we're at 9 p.m. with continued worsening imaging and exam. And unfortunately, she had even more eventful hours where she started having generalized hemoclonic seizures with severe acidosis. She was further loaded with antiepileptic medication and started on Versentrip pending EEG, because it was also at 2 a.m. So we don't have EEG, but clinically she was seizing, so started on maximum treatment. And then that's her repeat imaging again at 3:30, I think, a.m., where she has diffuse edema, midline shift, and this hyperintensity is like more post-contrast, and we can see here like that was at 3 a.m. Her scan that looks very bad. And at this point,
Did you mention venous hypertension and sinus thrombosis?
Correct. Yes.
Yeah.
And then the CTV was completely normal.
Uh-huh.
Yes, it was like here, like when we did, yes, like concern about venous sinus thrombosis. Her CTV, we reviewed also with the neurorad overnight. Everyone was, because in the beginning we had some doubts, but then overnight we spoke with the neurorad. They were like, no concern about it. They would say everything is completely open.
And you treated for epilepsy?
Yes, she was loaded initially with
Vimpat.
Keppra, Vimpat, and Versedrip. Yes, it was aggressively treated with everything. She had gotten also hypertonic prior on, and then the next steps, right? Like in the during the day, we discuss also with hematology, with all of us together. We say what's going on, like why, like after non-eventful cranioplasty, she keeps having this edema and strokes. So we even started on high dose steroids in case of catastrophic antiphospholipid syndrome, even though she didn't have any criteria for that. We say maybe she had an antiphospholipid syndrome that wasn't diagnosed. And at that point, there was also concern of unequal lower extremity pulses. So we say maybe she throws clothes. So we started on high dose steroids. And we continue like our protocols with ICP and status epilepticus management. So she was sedated with all the ICP precautions and on 2 anti-seizure medication plus Versedrip, hooked up on EEG that was like controlled. There were no seizures. And we continue maximum medical care. But we had a family meeting, right? Discuss all these news events. That was devastating for the family, knowing that this lady, she has like an 11-year-old girl. And we're trying to explain that we do everything, but we are not very optimistic, first because we don't know what's going on, and it looks that the prognostication as of now, it wasn't very favorable, right? But we said we continue everything, we give time, but we prepare the family for the worst.
What was your thought about her acidosis? Why did you think
from
she had such a bad?
So because she had generalized clonic seizures, so it was attributed to that. However, in that, because it was like overnight, I even thought like maybe she developed some mesenteric ischemia, because at that point we think that she has like new strokes. There was like concern of unequal lower extremity pulses, and she has that. So okay, maybe from the seizures, but we cannot rule out mesenteric ischemia. So we called gen surgery overnight. We assessed her like belly was benign. We even did a CTA abdomen that was normal. So that was kind of being ruled out as like first hypothesis, and we had the seizures that would explain, and then the next day it was starting normalizing. But
and
also
did you get her down to burst suppression? Did you?
Yeah, the EEG like the next day was like extremely with the Versed you don't really aim burst suppression, you aim control seizures and like no seizure activity on the EEG. It's most with the propofol that you target burst suppression kind, but her EEG was like completely like very slow with no epileptiform activity. So it was very slow. With she had like a high dose of Versed, 0.3 milligram per kg per hour. That was like approximately 20 milligram per hour of Versed. It was like extremely slow with nothing epileptiform, no activity. And then we were extremely perplexed at this point, right? What's going on? And then by looking, I don't know if anyone has any idea or any thoughts, like after an eventful cranioplasty, if they had any similar experience.
Well, we don't know why she seized.
Yes.
We don't know why she seized or why she stroked, but once you're in status and you've had a stroke, it could take a while before you recover. So just the fact that she's not recovering doesn't mean that you're not effectively treating her. We still don't have an etiology though.
Mm-hmm. Yes, that was like our point, right? But then by looking further in literature to figure out what's going on, actually it's something that it's extremely underreported and very rare, but it's well described. So after an eventful cranioplasty, after TBI or stroke, since 2003, it's very well described to have this pseudohypoxia brain swelling. And it's considered very rare, as you know better than me, the common cranioplasty complications, more like infections, bone flap, resorption, hematomas, etc. But the first case described in 2003 of a patient with developed stroke-like malignant edema after an event-free cranioplasty, usually it's described that it can affect both hemispheres, most likely contralateral, but also ipsilateral, and the underlying cause remains unclear. Predisposition factors described to that is the previous sinking skin flap syndrome, in case we do the cranioplasty early on. Trigger or precipitating factor is considered to be in every case described the application of suction drain, and in case there is concern for periop congestion, in case the dura is not very tight closed. And from 2003, that was the first case reported, until 2019, there are 26 cases reported in the literature. Here is a nice review of 2016 that reported everything until 2015. That was 19 cases. And to say that since after that, like there are more and more cases being reported and being recognized as an entity. The first case was reported in 2003. And then what these patients all have in common, they have most of them post-op trained. Some of them had seizures post-op, but it's not the rule. And also the time of cranioplasty is really variant. There are others that they have like at 9 even months. So it's very variant, the time of cranioplasty. What is extremely sad to that, it's like most of the time this condition is fatal, right? And then all these cases, all these patients died despite maximum care described. But again, we don't know the maximum care that was described from this hospital, but all of the cases reported have died. But it's an underreported case, so we don't know if patients recovered and it's not being reported. There are two hypotheses for that, for the mechanism as of now. It's like the one is the autoregulatory failure. So due to intracranial perfusion pressure changes, right? So as we know, based on the monocalary doctrine, like the skull is a closed, rigid container with a fixed volume. When we do the decompressed hemicrania after a TBI or a stroke, this sealed box concept is gone. And then the blood supply to the brain, the relative decreases, and there is like changes in the autoregulation. When the bone is placed back, then the ICP drastically changes. And that in some patients can lead to cerebral hypoxia and secondary brain swelling because of this ICP changes. The cerebral perfusion pressure also drops at the moment, and then that can lead to hypoxia and secondary brain swelling. Another hypothesis is the negative pressure theory that most of the authors of different reports, they tend to report that. Also, that was done, the 2003, the first case that was reported was attributed to that. It is thought that the concomitant elimination of the atmospheric pressure on the depressed brain with the negative pressure that we put by playing the vacuum drain, that can contribute. The negative pressure also change the brain shifting, and then leads to decreased cerebral flow. And have in mind, these patients have already very poor cerebral autoregulation. And that's like leads to brain tissue to expand in a very short time. So these are the two hypotheses, right? The autoregulation failure and the negative pressure theory. Of course, they're not really proved. To go back to our patient, right? So our patient, she did indeed have a sinking skin flap, like the initial scan, she had like a significant sinking skin flap syndrome. The cranioplasty wasn't done early, it was done 5 months after the decompressed craniectomy. And she didn't drain that much. It was like 150 cc reported when she had the exam change. What we did to our patients, at least maybe different from other centers, or I don't know what other centers did, they haven't reported, but we know that in our system, we have established since 2017-18, our ICU protocols for every ICU emergency, including ICP and status, but they're gonna be soon uploaded also in the Mount Sinai intranet. We're working on that. So we know for the ICP, she had here we have our checklist, right? Maybe it's too small to see, but No, we intubated right away. We didn't lose time to do CTA. We brought her right up in the ICU to intubate her and stabilize us first before completing any further imaging, got her hypertonic, and then immediately aggressively treat for her seizures with Versedrip and antiepileptic medication in loading dose and not just small dose. And then happily for everyone, like 5 days later, that's her DWI MRI. She has no new stroke. And the T2 flare, she has just minimum edema left, but the other hemisphere is perfect and there is no new stroke. And our patient, like 6 days later, she got extubated and discharged to rehab. And this is the first case actually reported in the literature that had reversible edema. So the initial interpret a stroke, it wasn't a stroke, it's the malignant edema as described. And it's the first time that's reported a reversible case with a very good outcome. And again, we don't know if it's the first time because we are the first to report it or the other haven't, but we have to be aware it's a very unrecognized condition. And that's her scan in November that she came to see Dr. Keller in clinic, like that's her scan, like completely back to her old stroke and nothing else with NIH of 6. She only has the left side weakness, but she's able to talk, to communicate. She's still in a wheelchair because of the left side weakness, but other than that, she's doing excellent progress. So the take-home message to be after this case, like for all of us, right? That these patients, like, okay, it's a cranioplasty most of the time, considered to be uneventful, and a simple case for when they come to ICU, especially for us, okay, when they should come to the ICU, but also in the ICU, we're like, okay, yeah, it's post-op cranioplasty. It's not considered the most high-risk patient post-op. However, we should be aware of this rare but fatal complication that we should act right away. There are like reports in the literature that they say that maybe some of these patients should have a preoperative EEG, because the question is how we can prevent it, right? So some of them had seizures. So there are some authors that, some specialists that recommend to do an EEG before. Our patient did got Keppra during the case, 1 gram, but as we say, like prophylactic antiepileptic medication, it's never indicated per se unless should be therapeutic. The drain, right? So the negative pressure theory, we know that you have to place a drain, it has to be in low suction. And then sometimes they say to keep the suction drainage system closed until the patient is recovered from anesthesia and has a good exam. As you mentioned, right, have in mind that there may be venous congestion, that the dura mater has to be very tight and well repaired. There are some that they say that maybe we should keep this patient intubated and sedated longer, especially if we consider they're like high-risk patients, and not rush to extubate them and to stop sedation. Of course, avoid hypertension. And in a real world, like that's the new thing to come the next years, to do a preoperative autoregulatory assessment in at least some patients, of course, with a non-invasive way, like to TCDs or use other non-invasive monitoring, some considered to be high-risk patients, to find a way to separate them in high risk that we should, for example, keep sedated or be more aggressive, or low risk. And that's some of the literature with nice case reports and reviews. And thank you very much. Happy to take any question.
Nice job, Spyridoula. Can you go back one slide?
Yes. Which one, the reference or the?
No, this one.
Yes.
I have such trepidation about keeping a patient intubated post-operatively, especially in a situation like this where they're already impaired, for fear of missing a fatal complication. And so I just, what can you say about that based from your perspective in the ICU?
I mean, I think that, like in her case, what may be saved here compared to other cases, that we were really aggressive also with sedation, because like sedation is the #1 treatment of ICP, elevated ICP. Of course, if we keep sedated, ventilated, then we may miss a clinical change. So maybe do as like a non-invasive assessment, do TCDs or other like non-invasive measures that we have before extubating the patients. We may even come in the ward to do some assessment with our TCDs in patients that they're considered high risk. So the question is, who is considered high risk? And the literature really, the only like precipitating factor that they say as high risk is like really the sinking skin flap syndrome, or if you do the cranioplasty earlier on. That's are the only two high risk like for complication, for this type of complication. But I think that it's worth to come with an idea if you like consider high risk as someone with a sinking flap syndrome, or if you want to do cranioplasty early on, that we might combine, do before the surgery. When we come to see you in your clinic, we can come do an assessment with TCDs and other non-invasive tests like optic nerve diameter, a combination of our tools, and then decide. We can do, even when you finish the case, we can do, and then with an imaging, and then decide if you have to extubate early on or no. Maybe we can come up with a protocol with that, because I mean, it's rare, but if it's not recognized and treated aggressively, it's fatal too.
Right.
And I think we were lucky in this case because we didn't even know what we were doing. We were just very aggressive because we knew her and she was 44 and it was like extremely aggressive. But if it was someone 80 years old, maybe we weren't that aggressive.
Spyridoula, how do you know? You know, you're referring to this case as this case, but
yes.
when you presented the data from the literature, all of those occurred weeks to months after. So how do you know this is the same condition?
No, the edema.
Didn't in the case series there wasn't the time period? Oh, that was the age of the patient.
Yeah, the age of the cranioplasty. Timing between the cranioplasty. It was immediately after an inventory cranioplasty, a couple of hours after the cranioplasty. That was the timing of the cranioplasty, like how months it took after the cranioplasty, like between the TBI and place back the bone.
So these all occurred acutely, just like yours
yes.
did?
Yes.
Okay, thank you. Kurt, did you have a?
Yeah, I had a quick question about if you think that for this case or similar cases, something like an ICP monitor or like a tissue oxygenation monitor would have changed anything, or do you think it's irrelevant for a case like this?
I think it wouldn't have changed, honestly, because her exam was good, and then you don't know which hemisphere is gonna swell, right? They say it might be bilateral, it might be contralateral, it might be ipsilateral. So assuming you place your ICP or your jugular bulb or your ICP in the infected side, then it might be the opposite. So I think it's hard to know unless you place something bilateral, or maybe do EEG, that maybe because might have an EEG change early on. But again, I think the difficult part is to know who is going to do it to prevent it from doing it, like to keep them maybe more sedated and longer intubated.
Have you looked at the anesthesia records? Because you know, different types of anesthesia can be associated with different types of changes in cerebral blood flow. You know, there's intravenous anesthetic, there's inhalational anesthetic. It might be interesting to know whether these patients were hyperventilated or not hyperventilated. If there maybe there was some momentary hypercapnia in the emergence.
Excellent point. Yeah, I'll go look further in the report. It was nothing reported, and when I looked, it was Edema and nothing reported. But I will. That's an excellent point. I'm gonna look ever like in the chart the CO2 and stuff. Yeah, that's a key point.
Chris, do you have any thoughts on this?
Thanks a lot, Spyridoula, for that presentation. This was an emotional roller coaster of a case where a patient had really made a good recovery after a very large stroke and a very challenging first hospitalization. You saw we took her back for a temporal lobectomy. So this was initially devastating, and then she ultimately recovered back to her preoperative baseline fairly quickly. I really don't know what was going on in this case. I think that there was definitely edema, so this does follow the paradigm that you identified, Spyridoula, and that's been reported in these case series. This patient did better than those patients did do. So is it the exact same phenomenon? It's tough to know for sure. We don't have any additional test or understanding of the pathophysiology really to take it to the next step of okay, fine, there's malignant edema. What caused that? I think abnormal autoregulation is a reasonable cause. We know that we saw hypodensity in the right side on those CTs for multiple days afterwards. So there was clearly some perfusion change. But then ultimately that didn't translate into ischemia. So one thing that's possible, like you were saying, is that the sunken flap, as the brain expands, the vessels are not able to accommodate that volume change and are not able to autoregulate and dilate sufficiently enough to supply blood to that tissue that now has a different geometry to it. That's kind of my understanding, and that leads to seizures and then edema. It's kind of my interpretation of it. And I think supportive care and, like you said, intubation, management of the seizures, management of ICP, if it needs to happen with additional decompression or an EVD, we didn't need to do that here. But it's an area to try to better understand. I think we really don't understand it yet.
I think Salazar has an interesting point. Do you all see that question that he's asking there? Was the hemovac output spinal fluid? Because if it was, 150 cc's is a lot over 3 hours.
I think it was only blood, but I will have to double check again the notes. But the only notes I found, I was looking at by all the, like in the moment, it was only blood, I think. And then also reporting some like nursing notes, like drain output bloody, but I don't have the concrete answer to that.
Yeah, it was blood.
It was blood, right? Yeah.
We don't apply suction to the drain.
Yeah, self-suction. Yeah.
Yeah, allow self-suction of the subyellow drain, and we hook it up after everything's closed in the case. And it did appear to be blood in this case.
Jorge, did you have a question?
Yes, sir. Thank you. Thank you, Dr. Tsetsou. Nice presentation. After you review the literature, what do you think made the change, the difference in this case to have such a good outcome? Maybe the high dose steroid protocol that you guys tried for the potential antiphospholipid syndrome? Thanks.
Yes, it's hard to know, right? I think it's a combination of very aggressive management and sedation, and intubate right away, back, sedate, give anti-medication, and all like hypertonic, and maybe the steroids help, but we didn't have any evidence for anything autoimmune or the catastrophic APS. But again, we are not 100% sure of what happened. So yeah, maybe the steroids is different that they haven't done in the other patients, and that maybe was the something that improved. But it's hard to say. But for sure, I think because like when I read the case report, they don't really focus on the management after. They say it was like catastrophic and they kind of withdraw care. But like we didn't withdraw, we like continue for a couple of days.
This condition reminds me of normal perfusion pressure breakthrough. And in the sense that there's autoregulation, thought to be an autoregulation problem after perfusion of a part of the brain that has maximally vasodilated because of the steel around an AVM. And one of the management pearls of normal perfusion pressure breakthrough, if you believe in it, is controlled hypotension. Because there's no autoregulation, you don't want high blood pressure, which drives blood through these maximally vasodilated vessels and creates more swelling, edema, and pressure. It's a testable hypothesis. Next time you get one of these, to try lowering the blood pressure a little bit. But this is a really fascinating observation and shows how little we do know about what we do sometimes. A really wonderful presentation. And I'm glad that she did it right. Sounds like we've exhausted all the questions.
Yes.
All right, thank you.
Thank you.